Unfortunately, that's not what I know.
No, it's not, but yeah, and then you can go, you'll have an opportunity if you miss something to go back and review that. I'm going to go through history and interviewing. Dr. Ballard actually prepared this lecture material for us, but I'll be talking about it today. And this is actually an anniversary for me because this is the very first lecture I did when I came to work here a year ago. So, all right. The history and interviewing process is, to me, the most important part of any clinical visit. You will learn more about your patient through this part. Do not rush through it. To me, and the way I was taught many years ago, is that this is where you really begin the process of differential diagnosis and begin to think about managing the patient. And so the history and physical exam becomes a very important part, and later your physical exam just really becomes confirmatory of already what you're thinking about. So I want you to really focus on becoming adept at this interviewing process. We're going to teach you some very orderly techniques, but over time you're going to develop your own style. You'll certainly get faster at it. It's going to feel like probably the most laborious thing you've ever had to do when you first start doing it. But once that process becomes part of you, you'll just flow through it just like you do your nursing assessments in your position now. The thing that I would say to you, and I think this is very common with any first time you first start a clinical class, is that you may feel like you don't know anything. And I remember the first time I stepped into a patient's room, even though I'd been a nurse a long time, when I became an NP, I felt like I was a fake and I didn't know anything. So that's a very common feeling, and I just want to encourage you that it's normal to feel that way because you become experts in the field you're in, and now, again, you've gone back to being a novice. But you still have all that information there. You're just going to learn to apply it in a new way. So that's what we're going to be talking to you about in this class particularly, and then adding some advanced concepts to that. During this interview part, you have to really enter into the patient's reality and kind of make sense of their world and understand that world. And so that's really the goal of this whole process that leads to diagnosis and management of a disease process. You want to negotiate and share in health management. And, of course, with all the new healthcare laws, prevention and management of disease by the patient becomes more important as a focus for us now. So we're going to spend some time during our clinical visit working with the patient on that and kind of getting a sense of where they are with their health care. And then counseling about disease prevention is also very important. You may remember back to the time in your BSN program when you talked about therapeutic communication. Does everybody remember that? Remember therapeutic communication? Oh, tell me more. Remember that? Okay. Well, we're going to expand on that a little bit. And when we walk into the room, there are the C's that are listed here, the 5 C's of courtesy, comfort, connecting with your patient, confirming, and then assuring confidentiality for your patient. All of these become a very important part of quickly developing rapport with someone in the clinical setting. And so that's very, very critical. The other thing that is sometimes challenging to individuals moving into an NP program is remembering to ask open-ended questions, because we're so focused on our process and trying to make sure we dot all the I's and cross all the T's that we sometimes forget to give the patient a chance to say something. And because we're so busy trying to get our form filled out that we're not really focused on getting them to tell us a lot of information. So you may find when you first go into the clinical setting that your preceptor is going to come in right behind you and the patient's going to say something totally different to them than what you've just reported to her. That's very normal because you're very focused on process, and you may not have asked the question in just exactly the right way to elicit the information, or they may have already developed a relationship with your preceptor, which is the case many times, and they feel more comfortable communicating with that person, or you may not have given them enough time, or they've had time to think about it since you left the room and now they have more to tell. So any of those things can be true, so don't let that discourage you if that happens, because it will happen. Once you've allowed people to give you information, then you may have to go back and ask some very direct questions about symptoms or things they've reported in the history. So the direct question really does seek very specific information, sometimes for clarification. Be careful with leading questions, as this can limit the information. One of the ones we'll talk about a little bit later, I'm going to try to abbreviate this a little bit in the interest of time since we have a long day, but one of the ones that sometimes happens, or is said, is, you have safe sex, don't you? What's the answer going to be? Yes, of course I do. We don't have another answer to that. So sometimes things that we're uncomfortable with, we'll inadvertently ask a leading question. And so be very careful with that, as that can cut off a part of the really important information that you need to get from your patient. If the patient, or you get the sense that your patient doesn't understand what you're asking them, you can encourage them to say more by saying something as simple as, could you tell me more about that? Repeating what you've heard to make sure you've gotten the facts straight, clarifying. You say you feel nervous or jittery. Could you tell me more about that? Would be an example. Show understanding and acceptance. A lot of this is done through your body language. You want to have a very open body language when you're sitting and talking to patients, especially if you have a computer there. And this is one of my pet peeves, is people who stare at the computer rather than talking to their patient. Please, please, please do not let yourself do that. I very often will take just a little, we use an electronic medical record, but I'll use just a note and take a few brief notes and chart outside the office, because I don't want to be staring at the computer screen. My focus should be on the person. Always listen to your patient. Always treat the patient, not a piece of paper, not labs, but your patient. That's critical. And this interview process is so important that I don't allow myself to be drawn away into a computer, because I feel as though I'm missing things that can be very important, because there may be one wince, there may be some indication when I ask a question that maybe the patient doesn't say anything, but I might detect that from their body language. Your body language is very important also. You want to have good eye contact, not staring, but good eye contact. Comfortable, open seating. Don't cross your arms. Don't look down. Interact with your patient. Act interested in your patient. That's very important to communicate in those very few minutes that you have with them. If there are disturbing behaviors that they're exhibiting, I notice you're kicking your legs a lot, or you're seeming anxious. Can you you want to point that out and say, is there something going on here that we need to address? And you want to repeat what you've heard to confirm their meaning, because patients have their own health languages, as you'll learn. I work a lot with older adults, and they're this is particularly true of them, because you can ask them if they hurt somewhere, they'll say no. But if you ask them if they ache or if they're sore, that's their language for hurt. So you may have to ask it in a different way. And once you become familiar with that patient, you'll know what their health language is, and you'll know how to communicate with them. But that sometimes takes a visit or two, especially with older adults or those that don't come to the doctor's office very often. They may have a very different way of describing things. So you may have to ask it again, especially if you notice body language that indicates discomfort as you're interacting with them. Here are some communication tensions that are listed here, and this can kind of become uncomfortable, and you may have to set the record straight. Patients, and this is true of me, my older patients, they want to know all about me, because this is a social visit for them. So they want to know about my kids, my grandkids, what did I do over Christmas, all of those things. And I'll spend a few minutes talking about that, but I say, I'm really here to talk about you today, and I really appreciate you asking about my family, but let's talk about you. What's bothering you today? And redirect that. You'll get better at that over time. You may find when you first go into a room, your preceptor is going to be tapping on the door at about 20 minutes and saying, "Are you done yet? Are you done yet?" Because the expectation in most clinics is that visits, at least episodic visits, take place in about 15 to 20 minutes. It's very volume driven in many clinics, and so you have to be efficient in what you're doing. So while you certainly have to balance that in developing rapport, you need to move along. And so you may have to learn how to redirect, and that's a skill that it takes some time to develop. There are occasionally issues that come up with patients who maybe behave seductively, those kinds of things, and you have to learn how to redirect that. And sometimes you have to be pretty stern about it and just say, I'm here as your health care provider, and that's not appropriate behavior. Our relationship is professional, and if you want me to continue seeing you, it has to remain that way. And you don't have to be angry about it, but you're just a very matter of fact and very blunt. And it sometimes takes that, and it usually takes care of it. If things like that escalate, you need to have a discussion with your collaborating physician to let them know that that's an ongoing problem, and you may have to make other arrangements for that patient. Documentation, this adage, which you've probably heard since your early days in nursing, if it's not documented, it wasn't done, is still very true. And this is true from a liability perspective for you. If you ever, heaven forbid, should be sued or the practice is questioned about a patient, it's also important for billing purposes, whether it's Medicare or private insurance, because you're billed basically upon what you performed at your visit, and your documentation is the only record of that. That becomes critical as you become a provider and you move into the billing world. If you don't document, it's not only was it not done, but you don't get paid. And to keep the door open, you have to document the work that you're doing. And also, if you're working in collaboration with other providers, you want to make sure that you leave a paper trail and an adequate record of the plan for that patient so that there's good continuity of care. Or if that person goes out of a practice to a specialist, then the specialist will have the appropriate information to make treatment decisions. So your documentation becomes infinitely more important. And of course, here's Dr. Ballard put us a lovely picture of soap. I just love this soap. But our soap is a little bit different that we'll be talking about today. And this is a method of documentation. I recall learning this very early in my nursing education, but it's becomes a little more sophisticated in the world of nurse practitioners. And it's a method of documenting an encounter with a patient that really can be tailored to any type of visit, whether it's a comprehensive visit, if you're going to meet the patient for the first time and provide a comprehensive visit, it can be tailored to that, and as well as a very problem-focused or short episodic visit. And that includes all aspects of the visit, from the patient's chief complaint all the way through the initiation of a treatment plan. And you have some examples of those. I know Dr. Ballard has posted some templates for you, and we also, in your book, there are some good descriptions of this. A SOAP note, as I mentioned, can be used for any type of visit and begins with subjective data, and this is what the patient tells you. And with your chief complaint, you want to write it in the language that the patient communicates to you. My back feels sore today. My ankle hurts, or I fell and hurt my ankle and now I can't walk. So those, you want to do a brief descriptor, but put it in the patient's own words. This is what the patient tells you. Objective data is what you, as the provider, see in your direct observations of the patient. And that uses all of the senses of seeing, hearing, smelling, touching. Those are all of the senses that you'll use as a provider in addition to other assessment tools. But those are the things that you observe. So remember, subjective is what the patient tells you. Objective is what you directly observe. And it's sometimes easy to get that confused, but if you think of it that way, it's a good way to divide it out in your mind so you can get data in the right place. The assessment is your interpretation, and that's after you've done your interview, all of your collecting of data, that your observations. This is what your interpretation, your diagnosis, your conclusions are as far as what's going on with the patient. And lastly, your plan includes the treatment, the testing, any referrals that you want to do, and you always remember to tell the patient when you're going to follow up or when they should follow up with you, or under what conditions they should follow up with you. Subjective data is obtained through the history. The history is obtained through our interview process that we've been talking about, and you can review these interviewing techniques in your Seidel and Goolsby texts. They both have excellent review of that. I would suggest that reading that will really help you with this first SOAP note assignment. If you'll go through that, read it thoroughly, maybe even just try your hand at it. It will really help you with establishing a good workflow for that process. Interviewing includes the introduction. You want to, of course, at this point establish the purpose, and I usually begin that by saying, hi, I'm Dr. Petersen. I'm a nurse practitioner with Dr. Dunn, and I'll be seeing you today. In your case, you'll say, hi, I'm Sandy Petersen. I'm a nurse practitioner student, and I'll be seeing you first today, and my preceptor will be seeing you afterward. That would be a typical introduction. You greet them with their appropriate title. I generally start with a very formal title like Mr. Jones, Mr. Smith, and they'll say, well, please call me Sarah. Then it would give you permission to refer to them otherwise. Introduce yourself, as I mentioned, and explain your role in their health care for that day. In interviewing, avoid medical jargon. For instance, if we're going to say, talk about or ask about a lab perhaps that's been drawn, have you had a CBC done recently? Your patients are not going to know what that means. So you might say, have you had a check for your anemia lately? Has someone drawn blood? So you're going to use terms that they're going to understand. And as I mentioned, I take notes sparingly, just enough that I'm going to remember the salient or important points. I'll keep a little notepad there if we use the EMR, or if you're using a paper record, you might just jot down a few things that are going to distract you from listening to your patient. Avoid leading questions, as we mentioned earlier, and you want to start with general concerns with the patient, and then I usually will list each of the symptoms and then go from a very broad description of that by the patient and try to narrow it down, because that helps me with the differential diagnosis. You clarify responses with where, when, what, how, and why questions, so that you know when symptoms presented. We'll give you a mnemonic in a little while that will help you with that piece. And then verify and summarize what you've heard. As I mentioned early on, this takes a little while at first, but you'll get more and more adept at it the more you practice. Again, try to use open-ended questions to get more information about their chief complaint, and then use closed questions to get very specific information, such as the one noted here. Do you use any recreational drugs? Direct questions to get more descriptors about a symptom. What was your chest pain like? Where did you feel it? And sometimes it's helpful to ask them to touch the area where they hurt or where they felt pain. That helps you even further delineate where the pain was felt. Permission-giving questions. These are really good, especially when working with adolescents or with sensitive topics such as STDs. Here's a good one as an example. Many young men I see have questions about STDs. What questions do you have? And that opens up and gives permission to the patient to talk to you about that very sensitive subject. And the use of silence. This one can be a little threatening at first, to sit there and your patient is very quiet and there's nothing going on. You kind of have this tendency to jump right to the next question. But some people need a little time to process what you just asked them. And so give them a minute to think about responding to your question before you move on to something else or you prompt them again. They may be having to process that. Clarification is always a good method as well to get more information. You say you feel out of sorts. Tell me what you mean. So that's, again, defining that health language that we were talking about earlier. And then restating to make sure you have the facts right. Is this noted here? Is that correct? Facilitation, and this is, of course, what we called in our undergraduate program is therapeutic communication. Go on. Can you tell me more? Tell me more. Oh is always a good one. And encourage them to say more and give them a minute to do that. The client and reflection is often helpful too here, where the patient says, I love my children, but sometimes they act so bad that I'm afraid I'll hurt them. And you see how that reflection is. You're afraid that you might hurt them? Tell me about that. Confrontation. In this case, it's someone that says, well, I don't care that this has happened to me. And you might reflect back as the provider. You say you don't care, but I see that there are tears in your eyes. So there's an obvious disconnect with what they're saying and what's going on emotionally with them. Interpretation. You're asking many questions about your pap smear. Are you worried about it? So being very attentive to the areas of focus for your patient. I'd like to hear more about your past surgeries in a minute. For the moment, I need information about your headaches. With patients who are kind of all over the board or get off on tangents, you have to redirect, and very often focusing and refocusing is something you're going to have to work on with them, especially if you work with individuals who have complex and multiple conditions or multiple chronic conditions, because you're not going to fix them. And you don't have the entire day to listen to all the things that are wrong, so you're going to focus on the one that is most affecting their function in life, or the one that concerns them the most. So you may have to redirect to get them to tell you which one that is or which one's giving them the most trouble. Again, that's a technique that takes practice, so don't be frustrated if you have the 45-minute visit sometimes. Common errors, changing the subject and interrupting your patient, social versus therapeutic response. That one can sometimes be a little difficult, where you don't use your therapeutic communication skills as we've been discussing, but perhaps respond like you would to a friend. I agree with you. You really should do this, and that's not a therapeutic response. False reassurance, everything's going to be okay. We can't guarantee that. Overloading and underloading, and this could be with information or just rapid fire questions that don't allow for the patient to have enough time, or giving them so much information. Sometimes that can be a problem. Jumping to conclusions. About, I guess, 6 months to a year in practice, there may come a time where you feel as though when you walk in the door, you kind of know what someone's got wrong with them, or diagnosing from the door frame is what I call it. Don't let yourself do that, because you will miss something one day that's going to be very, very critical. I had a good friend a number of years ago who diagnosed from the door frame because she was very, very busy. She was having to see 4 to 6 patients an hour, and she thought this person had a sinus infection when in fact they had meningitis. and she missed it. And the child eventually died. And to this day, when I talk to her, I know that she hasn't ever lived past that experience. So don't let yourself diagnose from the doorframe. That's something you never want to be too busy to do, is take time to listen to your patient and to really ferret out what's going on with them. The halo effect. There are patients that I have in my practice. There's one lady in particular who has a histrionic personality disorder, and she comes in dressed to the nines every time. She has lots of makeup on. Her hair's, she's got the big hair going on. And she looks really, really, really put together. And so it's real easy when you have someone like that to, and she comes off as being very well adjusted, but she isn't. She can hold it together for a little while, but she's got some very, very serious mental health issues besides her personality disorder. The halo effect is someone that's like that presents as though they have it all together. And you may assume that you don't have to go through your usual course of questions with those kind of folks. Don't let yourself skip questions. It's called the halo effect here, and I think that's probably good. We're assuming because they look good that everything's okay. And it may be not okay. I've talked to patients, and I've gotten to the part where I've asked about tired, or do you feel sad, or about anything, and they'll just break down crying. But if I had assumed everything was okay, then I would have missed that totally with that person. So don't let yourself be drawn into doing that. And of course, we already talked about the safe sex question, so I won't go through that again. But I'll give you one example of a faux pas that I made with an older gentleman. And I saw him in assisted living. He had 2 MIs. And he came to me 3 different occasions, and it was just for these non-specific complaints. And I'd been seeing him for a while. But with the older clients, I had gotten where I really didn't ask them about sexual activity. I just assumed, once you get past a certain age, you probably just don't have sex anymore. Okay? And this little man finally worked up the courage to come in and see me. And he said, I've got a little friend, and she and I have a little glass of wine at night. And sometimes we, And I said, oh, okay. And so I didn't know if he was going to tell me I'm living in sin, what he was going to say. And he finally told me, he said, is my heart going to be okay? And this poor little man, it took 3 visits for him to work up to asking me if he could have sex because he'd had 2 heart attacks. But I assumed, you see. So don't do that. Be very culture conscious, and if someone speaks a different language than you, make sure that you're aware of the provision in your clinic for different languages. Please, if you can at all avoid it, do not use family members, especially children, as interpreters, because this puts them in a bad place, especially if you're delivering bad news or asking sensitive questions of the patient. Your clinic should have a language line. That's what we use. We use an over-the-phone interpretation service. But find out what that is as you move into your clinical site and use that. Or they may have someone on staff who's bilingual. And be sure you're aware of who that person is and what the procedure is for doing that. And as you move into practice and begin interviewing for your position, ask about how that's taken care of. Also be very aware of people's personal space along with this. Because every culture is a little different about how comfortable they feel with the closeness to a provider and how a person can touch them. Some have to have their spouses present in order for you to examine them. And so that can be, in opposite sex examiners, that can be problematic for some cultures. So make yourself aware of that. If you're not quite sure, you can ask the person before beginning the exam, what's comfortable for them. Direct questions, validate and summarize, especially when you have these language differences, to make sure they understand. And then also, again, learning about the different cultural groups. Here kind of is a listing of the subjective data. This includes all of the pieces mentioned here. It may include progress since the last visit if this is an ongoing. The length of this and the content of this varies depending on your purpose with the patient. If you are seeing them first time, you'll want to get the more comprehensive listing perhaps all of these things, identifying their demographic data, writing the chief complaint in their own words, getting an HPI or history of present illness, finding out about past history. It might include family history with a genogram, personal and social history of abuse systems. But those are, if you were to do the comprehensive, it would include all of those aspects. This is, begins to establish that trust and support in a relationship with the patient, and to get information about them, and to uncover their health beliefs and their feelings about their health care. The health history, of course, identifies the date of the history, the source of history, source of referral. Occasionally you'll work with clients who may have cognitive impairment, and they may not be a reliable historian. And so you may have a family member who's able to supply you with that. Many of my older clients, since I work a lot with memory care, this is true. And so a lot of the data that I get at this point in the interview is from someone other than the patient, because they're not able to share this information with me. The chief complaint is their reason for seeking care in their own words. And it also includes the duration of the problem and major complaints only. As I told you, sometimes people will come in with a laundry list of complaints, but you want to find the one that you're going to focus on with them for this particular visit. And that may take a little ferreting out with you, because I do have patients who will tell me that 10 things are bothering them. And so you may have to say, well, which one are we going to work on today together? And which one's most important for us to work on today? The history of the present illness includes the lists of things here. It just, as I mentioned, it starts with kind of broad symptomatology, and you try to ferret that down. It includes your patient's thoughts and feelings about each symptom or complaint, and pulls in part of the review of systems, which is really asking about the status of each of their body systems. It also can include medications, habits they may have, such as smoking or use of alcohol, allergies, and since these are often pertinent in the present illness. Some practices have this written out in a specific format. As I mentioned, Dr. Ballard has written that out for you in the format that we'll be using this semester. The history of health history or history of present illness expands on the chief complaint. So the patient is giving you their statement of what's going on with them, and this expands on it. It gives a chronological order of the events leading up to the problem and kind of how long it's been going on. My favorite mnemonic for addressing the symptomatology is old carts. How many of you used old carts before? Heard of it? A couple of you? Okay. Well, this one is one that I think helps you as far as not missing things with symptoms. And so it's one that, and I showed one class, I still have the paper from my initial NP program that has old carts on it. And it's wadded up, and then now I have it laminated, because I carried around with, it's kind of a I guess a good luck charm at this point. But it's one that helped me learn that process, and that I used in clinical the whole time, because it was so helpful in getting information from my patients. And it helped me not to miss things. This will help you get the onset, the location, the duration, character of symptoms, associated signs and symptoms, aggravating factors, relieving factors, what makes it better, the timing, when it happens, and the severity of it. So these are ones that will help you with that broad analysis and to bring it to a very narrow analysis to help you make decisions about their care. This also includes, as far as our HBI, it includes getting some negative information. That's as important as positive data that you receive about your patient. Relevant family information. This may include some things about family dynamics, disability assessment, the extent to which the symptoms that the patient is expressing affect their function, their quality of life, things like that. Past medical history, of course, includes their past general health and can include any of these things that we note below. It could include psychiatric, medical histories, injuries, disabilities, and also includes health maintenance such as immunizations, screening tests, lifestyle issues, safety. And so as we go through and as you go through your management courses, we'll be talking more and more about recommendations and guidelines. So for instance, if someone's over 50, this would be the point which you might ask about, have you had your colonoscopy? If they have glasses, they should have an annual exam. You'll ask about when was the last time you saw the ophthalmologist, those kinds of things that you would want to know about that person to help them with health maintenance activities. The past medical history can also, as I mentioned, include these. It might also include medications, and just a word about medications. Some people, especially older adults, and I know I refer to that often, but it's because I work with them, I guess, so much, and I know some of their foibles. They sometimes consider that unless a medicine has a prescription label on it, it is not a medicine. And so, unless their doctor gave it to them. So, anything they buy off the internet or they get at the drugstore that their doctor doesn't prescribe is not really a medicine. So you may find that someone's taking, for instance, a whole bunch of Tylenol, but they don't consider that a medicine because their doctor didn't prescribe it for them. So they may not tell you about it. Also, these herbals are another huge issue, and not just older people, but with many people, because these firms have wonderful marketing campaigns, and they have everything from growing hair to looking 10 years younger to whatever it is. And you need to know about those because so many of them interact with our traditional medications and can have a true impact on people's health. So be sure and ask about those. Allergies to food, drugs, or environment, and of course, if they've had blood transfusions. Past medical history can also include birth history, feeding history, growth, developmental milestones. This is tailored especially with pediatrics. Family medical history includes identifying genetic or familial or environmental problems that contribute to the risk factors, and can include all these things here. We will ask you to draw a genogram, and that will be included in what you're doing for us. And these, of course, you try to go back at the 3 generations if you can. Not everybody has that knowledge, but you try as much as you can to complete it. Here's an example of one for you. The personal and social history is one that we sometimes kind of gloss over, but it's very important because it gives us great information about our patients, and of course includes the things that are listed here. This is a portion, for example, that would also include asking your patient about breast or testicular self-exams and about habits such as caffeine or alcohol use, and of course the other things that are mentioned there. Sometimes alcohol and drug use, domestic violence, asking about spirituality or sexuality, as I've shared with you earlier, can be very sensitive issues. And you may not elicit very much information the first time you see a patient. These are things that you may want to revisit again while you're with them on that visit, or if you have a suspicion that this may be a part of symptomatology, you can use additional questionnaires. The CAGE questionnaire is a very good one that you may be familiar with that refers to alcohol use and getting a sense of how much they're using. Have you ever thought about cutting down? Have you ever been annoyed by others criticizing your drinking? Do you ever feel guilty about drinking? Do you ever need an eye opener in the morning to get going? And those can help you. There are others, the taste questionnaire. These are common. There are others out there that are specific to age groups. And there's a adolescent craft questionnaire that's used many times for substance abuse. There are substance-related problems. And I won't go through reading all these, but it would be good for you to review them because they are very helpful. And have those at the ready if you suspect that someone's having a problem. You may want to, as I have, committed those to memory so that I have at least the CAGE questionnaire that I can roll out and use if I suspect that that may be part of a problem. Domestic violence is another one, and it has no age limits or cultural limits, and certainly is something that we have to be attuned to if we see bruising or emotional issues surrounding that. And again, it's a very sensitive issue. You want to ask if someone's hurting them, if a husband and wife come together, and I may suspect that, then they need privacy to talk to you about those. I mean, you're very frightened of their partners in the spousal abuse situation, so you have to be sensitive about that, but it's definitely something you don't want to ignore. There are 3 questions that are listed here that help you begin the dialogue about domestic violence, and I've listed those here for you. Have you ever been kicked, punched, or hit, or otherwise hurt? Do you feel safe in your current relationship? Is there a partner from a previous relationship who's making you feel unsafe? Those sometimes will be good at opening up. Here's another one. In the last year, this is a little more structured. In the last year, how often did your partner hurt you, insult you, threaten you, or scream or curse at you? Spirituality can also be a big part of healthcare, and patients may or may not prefer that you broach that subject. Here's an acronym that I think is very helpful in terms of determining the importance of spirituality and faith in terms of a person's health care. I, again, won't read through all these. You can read them, but the bottom piece is where you connect that and asking how do your religious beliefs affect your health care decisions. That's important for you as their provider to know. Sexual orientation is very important if you're going to provide appropriate health care. My practice is in Bel Air in Houston, and there are many gay and lesbian couples in my practice. And that was rather uncomfortable for me when I first began talking about their sexual activities. Some of the problems that they came with complaints were related directly to that. And so I had to get a little bit more comfortable with that because that was being raised as a very conservative person from Northeast Texas, and moving to that environment in my practice, it was a little difficult for me to get comfortable asking some of the questions that I needed to. But I've overcome that, and I'm much better at it now. Trust is usually better started in this area if you ask gender-neutral questions. Tell me about your living situation. Are you sexually active, and in what way? And this kind of opens that dialogue for them to be comfortable talking to you about that. As I said initially, it was very uncomfortable for me, having come from a very conservative background, but nevertheless, they've chosen me as my provider, so I have to respectfully address their questions, even though my beliefs and background may be different. And that sometimes is very difficult, so you have to become comfortable in your own skin, asking questions and being respectful of others' beliefs and activities, even though they may be different from your own. Sexual history, habits, their home condition, occupation, travel, all of these are part of that personal and social history. And for children, this is a listing of those. Nail biting, thumb sucking, those kinds of things. Temper tantrum, pica, the eating of clay. Still in some rural communities, parents will bake the red clay and break off little pieces of it and give to their children. They used that many, many years ago to hopefully combat iron deficiency. And so they may still do that, but it certainly can have other chemicals in there that are not helpful to children. Any rituals or playing with fire, if those are problematic, those are things we need to detect and address in the personal and social history for the child. And of course, you're interacting with the parent for the younger child, so getting that information from them is very important. Sleeping arrangements, dependence on a relief agency, resources in the home, presence of both parents in the home, or if that is the parent, sometimes we see a grandparent or someone who is even unrelated raising a child. So those are important aspects of that personal and social history with children. For adolescents, asking about home, education, employment, how are things going in each of those areas, and then our activities, if they're participating in drug or alcohol use, and of course sexual activity. Same thing for personal social history for the elderly. The focus here becomes more on resources, whether there are enough of them, if they have electricity in their home, if they have enough money to get by for meds and meals, accomplishments of ADLs if they're able to care for themselves, shop and do IADLs, and of course how they're doing with medication management. Review of systems, the goal here is really to go through each major body system from head to toe and ask about it. Most of the questions that you ask once you've received your chief complaint are going to pertain to symptomatology unless you're doing a comprehensive exam. With the comprehensive exam, you run through all of the major body systems. I do that as routinely with all my patients just in case it brings to mind something that's an associated symptom that they may not be thinking about presently, and it's very easy to run through that quickly. The review of systems includes all of the following that are listed here. As you can see, it's somewhat comprehensive, but it starts with the general appearance of the patient, their grooming and hygiene, whether they appear their stated age or not, whether they appear older than stated age, diet, nutrition, skin, hair, nails, all of those. And I won't, again, read through those, but those are the body systems that are reviewed. You start with general questions. How is your hearing? Any trouble with your ears? Any trouble breathing? Problems with your lungs? You have chest pain, trouble with your heart, and so on. General constitutional symptoms, these are address general functioning of the body, or general problems that they're having, such as fever, chills, malaise, fatigability, night sweats, and asking about their sleep patterns, weight, whether that's average, preferred, present, whether or not they've gone up or down in the recent past. Diet and nutrition include all the things listed here. And if you see someone, for instance, has had weight loss, you may ask about dietary recall. Tell me what you ate for breakfast this morning, or what you had yesterday for meals. Skin, hair, and nails, and of course you'll again asking about those, but your physical exam becomes confirmatory in this case. But you can ask about any problems that they've had in this regard. And I know Dr. Tina is going to be talking to you this morning about HEENT, so we won't go into that a lot, but asking about general status of this particular body system. And I've listed here some of the things that you'll be asking. I won't go again into detail since she will be talking to you about that. Neck and lymph nodes are part of this, looking at asking about masses or noticing any enlargements, tenderness, and so forth. Respiratory, shortness of breath, night sweats, any exposure to TB, those are things you could ask about, and especially as they pertain to symptomatology that's been stated earlier. Cardiovascular, again, chest pain. Endocrine, thyroid enlargement or tenderness, any heat or cold intolerance, changes in facial hair, body hair. Endocrine, this kind of gives you a list of things to ask. With females, we're asking about menses with males, perhaps testicular pain, trouble with erections, infertility, so forth, depending on the age of the patient and going through those. Hematologic, if they have a history of anemia, those kinds of things. Any past transfusions. GI includes these things, of course, from appetite to changes in stool or dark urine. Those would be appropriate to ask about. And, of course, with genitourinary, these may be specific things that you'll want to ask, again, to go from that very general approach to symptomatology to a very specific. So it could include any of these things that are listed here. Musculoskeletal includes joint stiffness or pain, any of these things. And neurologic, any seizures, weakness or paralysis, loss of memory. Psychiatric, depression, sadness, mood changes, sleep disturbances. And concluding questions for this very long litany of review systems. Is there anything else that you think would be important for me to know? And which of the problems concerns you most? What worries you the most about what you're feeling, and what do you think is going on? This last one is probably the most important, at least in my opinion, of these questions, because very often patients will give you their diagnosis from this one question, and it's one that I always ask. Sometimes you get those that say, well, you're the doctor, you're supposed to know, that's why I came to see you. But I always ask it anyway, because many times they have a pretty good idea of what's going on in their body, because they know it infinitely better than we're ever going to know it, since they live in it. There are some specific adaptations for age and gender, and I'm going to go through these quickly because, again, in the interest of time, I will encourage you to go back, please, and look at this and to read your chapters. With children, the one thing I would say to you is sit in the floor and play with them. There are two ways to examine children that I think are good things, just quickly, and I know Dr. Rath will give you some more wonderful tips, and she's our expert. But the main thing is do the quiet things first. If mom is holding the baby, you know that they have to be quiet, and you want to interact with them as much as you can in mom's lap, especially if they're showing fearfulness. Children who are older and curious, I will sit in the floor and play with them. And I learn a lot just by interacting with the child about their developmental stages. We don't do DDST specifically in our practice, but I do learn a lot about how a child is learning about their world, how they're communicating just by sitting in the floor and playing with them and examining them in that way. One thing that I use, for instance, with my 20-month-old grandson, he has a lot of ear issues, and I'll say, oh, let me look for Rudolph in your ear, because Rudolph is one of his favorite people. And I said, let me see if I see his red nose. So a lot of it becomes play in engaging the child, because children learn about their environment through play. So in any patient, you want to enter into their environment and their reality, and that for children is play. So that's how we can do a lot of that exam without making coming to our office a very threatening thing. Be very sensitive to their needs in that way. And the other thing I would say about children is that if a kid looks sick, he probably is sick. Kids, when they are sick, if they quit eating, if they quit peeing or pooping, or they just lump there, they're probably really sick. Would you agree with that, Dr. Rath? So that's just something, if a kid comes in and you can't really figure out what's going on, if they're up and around and tearing up the exam room, they're probably pretty much okay. But if they're lumped and sitting in mom's lap and they're just kind of not moving or not even responding to you, then they probably are pretty sick. You want to explore, I guess, again, all of those historical things with children, and asking the mom about gestational history and so forth. With adolescents, the big thing is respecting their need for confidentiality and respecting their impending adult status. And so that may mean that talking to them separately, but letting them know clearly that if you're not going to share information unless it's something that could impact them in terms of their harm. So you have to be kind of very sensitive in your approach to them, establishing an alliance, but also be very clear that you will share information if you feel that it's something that could harm them or impact their life. There are a couple of mnemonics with adolescents that you can review here, and again, it kind of goes back to what we were talking about earlier. The HEADS is one that I think that many people use that cover really major aspects of adolescent development. PACES is also good. You can take your choice, but I would stick with one and become very, very good at it if you see adolescents in your practice. Pregnant women in primary care, and in our practice, we don't manage pregnancy. We will manage up to diagnosing the pregnancy, and then we off them to OB-GYN and let the people that do that take care of them. But in some rural clinics, NPs do manage pregnancy. And we have, I know, a lecture later on where we talk about this specifically, but the main thing there is teaching about healthcare practices and important things, learning important things about the pregnancy and their obstetric history. These are, and of course, detecting any potential risk factors and making sure that appropriate referrals are made for those individuals who are detected to be high risk in their pregnancy. With older adults, this is a time when we have to take in consideration that the body ages and may slow down in some of its operating functions. There can be some sensory loss, visual impairment, cognitive impairment, all those things that can impact someone's health. What I like to do with older people is spend time just talking with them about their past. It's a real honor to get to take care of people at end of life. It's almost like they've given you a treasure chest that's their life, and you get to explore that with them. And I particularly like that. But it's also a time when they can be impacted greatly by multiple chronic diseases, and their key aspect is not curing them, but managing those diseases and keeping them safe, and finding out how you can get resources together for them to help them have a good quality of life. Patients with disabilities, you may have to adapt your interview process to meet their needs. Family members are often helpful in this regard. So those are just a few of the different populations you may see, and some tips for those. As I mentioned earlier, there are different types of history. I won't go through this again because we've kind of talked about that, except to say that you, in your primary care practice, much of what you'll use is a problem-focused history when people come in to see you for acute events. And that's just when you consider kind of the need of the moment and you address that particular need. So you won't necessarily do as extensive a history as we've talked about earlier today. And are there any specific questions? I know I went through it rather rapidly, but hopefully that gives you a good launch to reading your materials in your books and understanding a little bit more about the interview process. Okay, very good. Thank you. When you're ready to
All right. I'm going to show because I'm going to skip to a certain part. Good morning. It's almost lunchtime. You guys have had a morning of it. I have pre-recorded everything I'm going to say, and I'm going to do a couple of demonstrations. My name is Dr. Amy Tu, and I'm a family nurse practitioner, and I love teaching nurse practitioners. You are my breed. So it's going to be fun. I need everybody to reach over their ear. We're going to do head, ears, nose, and throat. And can you reach to your ear canal, your external ear canal on the other side? Well, you guys are all tall enough and big enough to be in school. That's what they do in Africa to figure out if you're big enough to go to school. You have to reach over there. How do I know that? I've lived there for 6 years. And but I'm not going to go back through this entire thing because it takes too long. I want to focus on some of the things that are difficult. And we're going to start on thyroid. In this class, you're going to have a partner, and you're going to get to know this partner better than you really want to. And so I'm going to skip to my thyroid pictures. Let me do it the easier way. Okay. Now, your thyroid gland is located in the neck. Surely hope so. And I need you to get with your partner. I need you to look at their neck. Everybody's got a neck. And you guys are beginning to fade, so I got to move you a little bit. Okay? You've got 2 lines in your neck. What I need you to do is go ahead and put your hands on your own thyroid by putting, you've got 2 folds. Put your hand right on it. Put your hand on the other side. Try to swallow. And you might feel your thyroid. It's harder to do on you, and so what you can do is, the book talks about pushing on one side and palpating on the other. And you can do that on yourself if you cross your arms. So you can push it, your thyroid, the trachea, one side, swallow. And I don't know if you guys can hear my swallow, but I sure can. And you push it the other side, but that's where your thyroid is. That's one of those that is more difficult. How big is a thyroid? That's the question that comes up often. And they might say that it's 3 inches wide and 2 inches tall, but what do you feel on the sides is the question. And it's about a quarter. The size of a quarter, the thickness of a quarter, slides up and down. And on some kids, you can't even feel it, but you're going to go ahead and start palpating the thyroids on people. When a child is born in the hospital, they're going to have a TSH, which is going to be a thyroid-stimulating hormone test, because untreated hypothyroidism for 6 months can lead to mental retardation. And it's so preventable, and so that's why it's often repeated at the 2-week check, just in case a borderline hypothyroid was missed. So these are some of the tests that you would order, and it would be done in the hospital, and when most nurse practitioners will see the child for the first time in family practice is at the 2-week check. How many of you guys are education students? Okay. I like education students too. Okay.
Well,
I double majored. I was just...
Well, I have a degree in community health education.
Okay. All right. No, there's some that are getting their MSN in nursing education that might be in this class, so I just wanted to find out. Okay. Now the thyroid, how are you going to do it? It's easiest to do it from behind. But if you have a patient that doesn't like being grabbed by the neck, or a young child or somebody with anxiety issues, you can't do it that way. I know your book talks about pushing it over with your thumb. Every nurse knows, just don't do anything with your thumb. You know, use your fingers because your thumb is going to push and hurt more. All right, so here's the picture of the thumb, which I personally don't care for. It hurts. Here's thyroid, and this is multinodule. Realize that it can be multinodule, and this tends to be in people. This was one of my patients that have an iodine deficiency in their diet. And the iodine is usually in salt, and so these are the countries of which they get their salt from the sea. Okay, I'm going to keep going through the head. I want to tell you a couple of rules of thumb that you really need to know, and I've mentioned them. And when I say that's something you need to remember, it's truly something you need to remember. It's my cue. This is probably testable material. And so you have to remember when the head circumference and the chest circumference, they should be the same until about 2 years old. And then after that, they're going to start separating. You have in your text, you've got a lot of pictures of these assorted syndromes. I'm going to talk about some of them. The parotid gland tumor Now, how would you know a parotid gland tumor versus any salivatory gland tumor? Well, you really don't, because it can be right at the mandible, and it's hard to tell. You can feel the two of them. They can be unilateral or bilateral, and so I say don't try to overdiagnose things. You can do a soft tissue CT and find out. Okay? This is Paget's disease of the bone, and that's what you call a bossy forehead. And we've got a few on Bell's palsy. And what you're looking for on this particular face is you have them smile, and you see if their eyes move. And you see at this lady, both of her eyebrows are the same. It seems like she's got the facial droop from the cheek down. Does that make sense to you? So you're going to look at your trigeminal nerve that comes up, and one goes behind the ear, one in front, and one down the mandible. So, and you're going to see if there's any pain when you palpate that. And she did not have that, and this is Bell's palsy, and it's cranial nerve number 7. Okay. The book talks about percussion of the skull, and that's usually not done, but there are times when you're wondering, is that fluid on the outside of the skull? Because as a baby goes through the birth canal, the vaginal birth, it's not unusual that there will be some edema right under the scalp. That tends to go away in about 2 to 3 days. And it tends to, and it doesn't get any bigger. But that's when the percussion of the scalp the book is bringing out might come through. And let me see where I'm at. Okay, we're going to talk about the external ear and otoscopic examinations and hearing evaluation. And I'm going to spend some time on the ears and eyes because it just takes a lot of practice to be able to do that. Okay, when you have an ear, you've got the external auditory canal, and also called the auricle. And you'll look into the ear canal, and you're going to see the tympanic membrane, which should be pearly gray. And that's the window that, after that, or more medial to that, becomes the inner ear. You need to talk about and know how to describe the ear lobule itself. The lobule is the bottom, the helix is the top, the tragus is in front of the ear, and the antitragus is behind the ear. Okay. Inside the ear, you've got the 3 bones that vesiculate, the malleus, incus, and stapes, and and hearing is just an interpretation of the sound waves that travel through that eardrum. One of the big things you really want to ask about is any childhood problems that they've had, and any surgeries, and if they've ever had any kind of antibiotic use of particularly the drugs that end in mycin. Gentamicin would be one, but that have the suffix of mycin are the ones that are harder on the ears. One of the childhood problems, and I've got it down here somewhere, is how many vessels that are in the cord, the umbilical cord. Was it a 2-vessel cord or was it a 3-vessel cord? And because 2-vessel cords have problems with hearing and problems with kidneys. So that's why that's important. Okay. The other problems that I want to just stick with the ears, so I'm going to skip through the throat. You want to ask if there's any kind of allergies, because you can just have fluid up that travels from your stationary tube and your sinuses and goes to the inner ear. And that's just allergies. And if you can control the allergies, you can improve the hearing. We've all had that experience where you fly on a plane, your ears get full, you can't pop them, or it's the same thing. And you don't hear real well, and sometimes you'll hear some ringing in that ear until you get that ear to clear. And there are a couple environmental hazards to hearing, and the biggest one is noise. And the other, this intranasal use of cocaine, that goes with nose because they put all the hearing, ears, nose, and throat together. Okay. On the external exam of the ear is the auricles. You want to look for size, symmetry, and shape. You want to look at the position on the head, and we're going to talk about how you're going to know what's normal. What's the color, and is there any discoloration, and the presence of any deformities, and you're going to inspect the external auditory canal for any kind of discharge and odor. And so when you go to look at the auricle, you're going to notice that in these pictures, and these are also in your book, and the very first one, which is labeled A, you have got a auricular sinus right here. It's kind of hard to see in this picture. The second one is going to be that you've got a Darwin's tubercle. The third one here is where you're going to have a cauliflower ear, that it looks like a cauliflower, purportedly. And you got a squamous cell carcinoma, sebaceous cyst, and a preauricular tag. These are common findings that you're going to find in the auricle of the ear. What you want to look for in the ear is the outer canthus of the eye. If it will cross over and hit the helix of the ear. And so you want to draw an imaginary line to see if it does. And it should. Otherwise, they're called low-set ears. And then the position on the head itself. You want to know if it's going to be a 10-degree or greater than 10-degree slant. So what you're going to do is right at the very bottom of the ear by the lobule, you're going to just draw a line straight up and draw a line over from the outer canthus of the ear. And this is where you measure this 10 degree. Okay? You can do this on everybody. And why would you really be concerned about that is a lot of the genetic disorders are going to have posterior set ears or low set ears. And so that's how you can tell, because sometimes the skull is, it's a funny looking, they call it FLK, funny looking kid. The skull has just shaped as it's gone through the vaginal canal, and you realize the sutures of the skull are not ever going to totally harden until young adulthood. So it will mold and move as the brain grows. And so a lot of these fine-looking kids, if they weren't a facial presenter, tend to adjust over time, and the skull will adjust itself. But you do need to know the setting of the ears. One of the things about ears, and we're going to talk about an internal ear exam, to look at tympanic membrane, is that people will look at the color of the tympanic membrane. And one of the reasons why color is problematic is, one, sometimes there's some wax in there and you can't see the tympanic membrane, and so you go ahead and you try to remove that wax. If you can see around it, just leave it. But one of the problems is that if the child cries, that whole tympanic membrane is going to be red. So you have to come back after the child calms down, if that occurs, and look at the ear. So I'm going to talk real quick on how to put together your otoscope so we can do this. And you've got a handle. The handle is nothing but a battery. And you've got several heads in your diagnostic kit. And this diagnostic kit comes with its own little light, and you just put them together by putting them in and turning and screwing it, and you've got yourself one expensive flashlight. It's about $500, but it works nice. And then you can screw on your otoscope head, and you're going to pick the biggest speculum you can get in the canal, because that's going to allow you to see the biggest space. And the biggest speculum, it comes in two sizes. This is a pediatric size, and adult has got a wider hole at the end. When do you start using adults? Somewhere around 2 years old. And you put it in the ear, and when you put it in the ear, then the book talks about having something to anchor on. So before you touch any ear, you're going to put your pinky out to where you'll be able to, if the child moves their head, you're going to move with them. When you go into the oracle, and you're going to go ahead on somebody that's under 2 years old, you grab the globule, and you're going to pull down and back for under 2 years old. And that's because that ear canal is more horizontal and it's wider than, and so is the station tube. And this is why kids under 2 get a lot of otitis media or ear infection. Once the kid gets to the running stage in their development, their ear canal starts to have more of a downward slant. So after that, and on the adults, you're going to pull up to compensate for the downward slant and back on the pennant. You insert the otoscope into the ear, and you look through the lens. There's 2 different types of lens. One's called a max view, where you can see 30% more than these old ones. But these old ones allow you to slide it over to the side and be able to put an instrument through there and with a visual assistance to be able to take something out if you see something in the ear. Because your book talks about transilluminating the skull, I want to show you, this is the nasal tip. And the nasal tip, the green thing, cover, and this goes in the nostrils. And you see it's bigger, but you just screw on this tip. And I did that without, the light can be real dim, or I can flip it to the left and it gets brighter. But this will allow you to transilluminate and do the ET and impress your kids at home, that you can say ET from home. But you can also, if you're going to transilluminate any of the sinuses, you can do this, and the darker the room, the easier it is to see, especially the darker the skin. So the place you can practice at your house would be in your bathroom. They tend to be dark rooms. And you just have to have a willing participant to be in there and let you look at all their things. The sinuses, there's 2 ways your book talks about it, is to go ahead and put your hand over it and to transilluminate up for your frontal sinuses. And what I like to do is, if I can get the lights out, I will just go ahead and put it right on it, and you can see that both sides of the frontal sinuses and the ethmoids in the middle will be equal bilaterally. Of how it will be obvious when one is occluded, because one is dense or dark and the other one glows. On the maxillary sinus, you simply put it over the maxillary, open the mouth, and to be able to see through the mouth, see a light. Okay? They've got good pictures of that in the book. And they also have got little video clips that you can look at. But I like this transilluminator tip for transillumination for the simple reason that, and this tip comes on the nasal speculum, it never gets hot. And if you use your otoscope tip, it will eventually get hot. And you transilluminate a lot of different places on the body. And one of them would be, I use transillumination a lot. I'm trying to get like a splinter out. You can transilluminate the scalp. You can transilluminate the sinuses. You can transilluminate the testicles. But if you have a hot instrument, when you get down there, you don't have a very happy patient. And you hurt them and they leave. So be forewarned, change your tip. Okay. And then the last part is the ophthalmoscope. And the ophthalmoscope is a different head, and you turn it on. I'm going to just get done with the scope and put this away. But the scope, what you've got to do with this is an older model scope. There's the panoptic scopes, and what does the school have?
We have mostly those for them.
Okay.
That's what they'll learn on, but we have one or two of the
Panoptics. Okay.
They're really cool to get to practice with.
And the panoptic, if you go look at a Welsh Allen site and you want to buy a kit, it's cheaper to buy the panoptic the first time you buy a kit than to add it later. The school does have these kits. It's up to you to decide if you want to buy it or not. I have my own kit. I'm on like my fourth one. And I have no stock in Welsh Allen. Before I say this, I'll just tell you. They replace their products and they handle it well. You get good customer care. And it's a good quality product.
I have the same one I had in school.
Okay.
It's like 27 years old.
I keep having my nurses plug them in wrong or into 220 or I've blown them up. But anyhow, you can get a Welsh Allen. There's a couple of things, tools of the trade that you need to put your money into. And one is a very good stethoscope. Okay? The second is, if you're going to buy a diagnostic kit, buy a high quality one. Because the difference is all in the fiber optics of the light. And if you can't see, you can't diagnose. So I'm going to show you how you would go ahead and adjust the ophthalmoscope. And you notice I have glasses on, and I'm like really blind without them. So you want to start at 0. And that's a neutral area. And you're going to go up or down based on what's going to be your sight. You look, even with the panoptic, at something that's about 6 to 10 feet away, and you try to focus it to where you can see it clearly. Okay? I've got it seen clearly. And I'm on a red one. And 1 is negative and green is positive, but it doesn't really matter. They come in colors, so people just call it red 1 or green 1. But you know which eye examines which way. And so some people will switch eyes, and when you're on the panoptic, you don't have to switch eyes. On this one, if I have a patient facing me, and I use the right eye to the right eye, and I have to get real close, we're going to be bumping noses after a while, but over time you learn how to do it farther and farther away. But when you first learn, you're going to end up getting real close, and the problem with that is they breathe on you, you get sick, and you don't go to work. So you learn how to do it at more of a distance, so you're not breathing on the patient, and the patient isn't breathing on you.
And really learning how to change eyes, because it's good to
be able, like on their right eye, I'll use the right eye, and then I can use the left eye on the left eye. And in that way, you're not bumping noses at any time. Okay? And you're going to also see a dial in the front here. And this dial is going to let you see, here is a large hole, here's a medium hole, or light, and a small one. So make it easy on yourself. Get the large one. All I'm doing is turning this dial. Okay? You also have got one that has a blue light. You've got one with a split lamp and with crosshairs. So you can kind of judge just diameters in the eye. So I'm going back to the big light. Okay? And that's all the lights you're going to get on this. You can move this, there's one little knob in front of it, and if for some reason you go like this and you don't see any light, if you have this just slightly off on the top, it's going to screw up your light. So just make sure it's on the middle button. All right? How do you charge this thing? Well, if you've got a silver handle, you unscrew one part, screw on another, and stick it in the wall. On this is a lithium what kind of handle? Some kind of battery, lithium something. And all you got to do is you've got a little charger. You punch the charger, push the two together, turn, and out pops the prongs. And you just do the reverse to only use your handle. Okay? What's the difference between the silver handle and the black handle? The weight. Okay? A lot of it's just the weight, because the other one's got a different type of battery. So if you're carrying this in your pocket all day,
This is supposed to have a longer battery life too.
it does, and it has a more durable, they say this is the same material they make NFL helmets out of. So that's how you use your diagnostic kit. Any questions? You want me to put it together again, or you got it? Okay. You just have to play with them.
When do we get those? We usually get them the first lab, but that's a month. So I'm going to have to go talk to Doug at lunch. He's the lab manager, and see if we can get them this afternoon.
Okay, one other thing. If your two parts don't go together, this is a common thing. You've lost this adapter. You put it on another thing, because it goes on a lot of different tips. So just take it off, put it on, and screw it on. I want to talk to you about the tips real quick. Depending on the type of handle, there's different tips. And this is one of the newer handles, so it has a tip that's got 3 little cogs sticking out of it. And the nice thing about that is you can pop that off easily and just put it in the trash. It's not popping. The Max View, you can turn the whole handle. That is really cool. You can just flick it with one handle, and then you don't have to go and get everybody's earwax on your fingers. But I had it on too tight, but you can easily pop them off and just put them in the trash. And again, it's not popping. But that's the tips that you would use. There's different tips for different type scopes, but it doesn't matter. You're going to end up in a clinic that doesn't have the tip for the scope that you have on the wall, because they found some free tips somewhere. So you just learn to stick your finger on the edge of the tip, and you're going to be okay. It will stay there. But it happens on every otoscope that the tip won't stay in, and you're sticking in somebody's external canal, and you'll leave it in there when you back out, and it's not a big deal. Just take it out and act like that's normal. So, okie doke. Tympanometric configurations, and what do they do? That's another Welsh Allen product. And what they do is they measure the flexibility of the tympanic membrane. And where they come into play is if you have otitis, serous effusion is one name of it, or you just got fluid behind the ear, and you're not sure how bad is that fluid and how much is it allowing the eardrum to move with the sounds. And so what this is you put it in just like in a temperature thermometer, and it just goes in the ear, you press a button, and it prints out a tape that comes out similar to what you get at the grocery store. And this little tape will tell you what you're dealing with. If it has one would be a normal, where it will move. See how figure 1 moves? Here's where you insert it in the ear, and then the drum moves whenever you go to register it. And that's going to let you know you got a normal middle ear system. 2 and 3, you've got some otitis media with some retraction. The drum is not moving. And number 4, you've got a stiffened middle ear as a consequence of having adhesive otitis media, otosclerosis, or thickened tympanic membrane. And then on 5, it's letting you know that you've got some kind of disconnect with either the 3 bones that are going to move or the tympanic membrane itself. There's no movement in this picture. Why is this important? It's important because, and by the way, if you're using the school supplies, they come with a little cloth to clean it. You can really scratch the lenses if you use paper towels, so don't use a paper towel, and just use the little cloths that come with it to clean up your instruments. Why do you want to go ahead and test the flexibility of that drum? What would be some of the examples of that? Okay, if kids are having recurrent otitis media, they might have some fluid that's staying there. The second thing is, if you've got, we're going to see a picture in a little bit that's going to show if you've got a tube in the ear, you want to make sure that the whole eardrum will move. Sometimes you can have some epithelial cells behind the eardrum, and it will present as white. And we got some pictures of that too. And you want to see how much rigidity is there in that drum, because the drum has to move for hearing to occur. So why would you really be concerned? To make sure that there's going to be good hearing. Second, sometimes you want to know how much it's going to move to where you can do a pre-authorization for tubes for a child. So those are some of the common ones. And the offices that have them the most are pediatric offices.
If they don't move at all, can you authorize them for tubes, or would that mean in case you need them?
It depends on the history. And you're going to, if they're not moving at all, you're going to probably send them to an ENT. Because an ENT is going to be the one that's going to do something about it. But the rule of thumb is you have to have 3 otitis media infections in the last 6 months to get a lot of them authorized. So even if it's not number 3, you need to document it so you can see a pattern so the parents can get tubes should they need them. Okay. You're going to palpate the auricle in the mastoid area for any tenderness and pain, because you can have ear pain, but it might really be mastoiditis. So that's why you want to palpate around the ear. You want to note any swelling or nodules, and the consistency of the auricle should be firm and mobile without nodules. Here's one of the things I talk about in the lecture, but it's hard sometimes to get things across without showing them. But everybody will talk about the recoil of the ear. And what you do is, if you go ahead and flip your lobule, see how it will flip. But as you go on up to the ear towards the helix, you're going to find that there's more cartridge on the antitragus area. And see how that snaps? And then go up to the pinna and it snaps, but it's a little more floppy. Is everybody with me? Okay. Preemies, when you snap their ears, they have more floppy ears equivalent to the top of your pinna. And full-term babies will have a snap recoil similar to the antitragus. But you want to see what the recoil of the ears are, because that's going to let you know some of the development or the gestation of that baby when it was born. And it should be firm and mobile. And you're going to look for full formation, flexibility, and tympanic membranes or conial after the first month. And evaluate infant hearing, sounds, and how they respond to stimuli by clapping your hands, snapping your fingers, and you're just looking if the child looks towards you. Let's go into the otoscopic exam. You're going to look in the tympanic membrane. You've inserted the ophthalmoscope into the canal. This is after you've already palpated and inspected the auricle. And you're going to look for any kind of discharge, redness, scaling, lesions, foreign bodies, or cerumen. And I'm always amazed at what people will put in their ears, and it's usually those right around 2 years old. You find the oddest things in their ears. After a while, they realize they don't want to do that. But you're looking for landmarks, color, contour, and perforation. So here, this is one of the older otoscopes, and just inserting it into the ear of the gentleman. And you can also test the hearing by a whisper test, being able to stand 3 feet away and whisper something. And the clue to that is, if you're going to test the right ear, you want to be on the other side of the patient and occlude one ear. And so you'll be able to know which ear is hearing and which ear is not with the whisper test, about 3 feet away. Ticking watch test or tuning forks for the Weber and the Rhine. Now the Weber is this picture right here where you're going to get a tuning fork, you hit it, you put it in between on the top of the cranium, and you're going to ask them if they hear it in one ear or two. And if they hear it in both ears, that is normal. The Rhine test is this one over here to the left, and what you're doing is you're putting it on the mastoid area, and you hit it, put it on there until they no longer hear it. And at that point, you put it over the ear for ear conduction. And the air conduction should be twice as long as bone conduction. So that's where they get this 2-to-1 ratio. Air conduction is twice as long. So what's going to be a normal or a positive, Renee, is sound is heard twice as long by air conduction than bone conduction. Negative shows that you've got some conductive loss. The sound is heard as long by bone as by air, or a little less. Sensory neural loss, and this is what happens as people age. There's a normal ratio of air conduction to bone conduction, but all of it's reduced overall. They're just not hearing as long as what you would normally have an adult hear, and which is around 10 seconds, and you have to time it with your watch or your phone. Okay, the common abnormalities of the ear are otitis externa, otitis media, cholesteatoma, and that's where you've got the epithelial cells built up, and otosclerosis, Meniere's disease, and Lambertitis. So let's go ahead and get to the ear. You've got a couple of parts on the ear, and I brought the bones out so you can see the short process of the malleus that will stick out, and then you can see the manubrium. So here is the short process, and here is the manubrium. This is your cone of light, and this right here is the right ear. And how do you know that? Is the cone of light will always follow the jawline. So you know it's going to be at 5 o'clock on the right ear, and it's going to be at 7 o'clock on your left ear. The pars tensa is right back here, and it should be pearly gray. So what we have in this picture, and these are pictures in your book, and this ear, what is this? Everybody know? Cerumen. Okay. It comes in two colors, white and black. And white is more dry and scaly and more common in Native Americans. And the black, this is something genetic, that if you produce it, you produce it. The purpose of this rumen is to keep the bugs out from the tympanic membrane. And this right down here is a tube. Okay, otitis media on the early stages, you're going to see that there's some erythema, but you can see down here that it's a normal color, and you can even still see the cone of light. And it's in the place where you'd expect it at 5 o'clock. And that means the ear is not bulging. If the cone of light is not at 5 o'clock or 7 o'clock in the left ear, there's some bulging from the inner ear out. Okay? It moves the light reflex. I got some puzzled looks.
So that little streak right there is the 5 o'clock.
This little streak, this is a right ear, and it's at 5 o'clock. So you're going to expect it at 5 or at 7, or else you know you got some bulging coming at you. Here's otitis media in the late stages where the erythema is almost throughout. This is a tympanic membrane that has been perforated. See the hole?
In the early stage, was it just the opacity that you're seeing different, not the cone of light?
And some erythema here. Can you see that? Mm-hmm. Well, I don't know how to turn the lights down, but on the PowerPoint, it's easier to see than in this room, but I see your point. You can't really tell. Which ones do you want up? Just these front. Okay. Does that help? Okay. And this would be the late stage. You see some more erythema. And the perforation, with the perforation, you can see the short process, the entire short process down to the manubrium. You can see the whole thing. It's quite retracted. So,
On the late stage of otitis media, we lost the cone of light because of the erythema or because it's bulging outward?
both. Both.
So if you see it bulging outward, does that just let you know?
That you've got a fluid back there, and if fluid stays there 48 hours, it's going to start getting infected.
Even less than that in a child.
But is
So-
it worse that we can't even see the cone of light there?
Well, it's significant. One of the things that you have to do, and I talked about it on the PowerPoint, is open that eustachian tube. And you can do that with nasal steroids, a shot of steroids, or some oral steroids to open things up for this person. Air bubbles. This picture is not in your book, but you'll see this a lot, so I wanted to bring it to class. These air bubbles are what you're going to see sometimes, and the cone of light's in the right place. But through the tympanic membrane, you see these bubbles of air. And that's on somebody that has done, have you ever seen the people that sneeze and hold their nose? Okay. They blow some air bubbles occasionally in their eustachian tube. You see it sometimes with scuba divers that go up and down, and don't get their ears cleared all the way. But they're painful. And once again, you've got to open the eustachian tube to let it out.
It can happen, too, whenever people fly and they have, like, head congestion and stuff and in their ears. It's sort of like diving when you fly with the head.
Yep. But it's a real painful condition. So you want to open it up for them. Okay, and the cholesteatoma, what this is this white cells here that are epithelial cells. And that's from repeated infections. And they build up, and they will be there for life. And they will be in the middle ear, but you're going to see this white blob on the tympanic membrane. Okay, and this right here is a sebaceous cyst. Okay. You take a hint from the inside of the cheek. Look in the cheek, inside the cheek, and the nose should be one shade redder, or in a black person, one shade darker than the cheek. And that's the only thing I can tell you, because they come in so many varieties of colors. Not every one is going to be bright red. Not everyone's going to have copious amounts, but there will be a darker than the cheek, and it will be more than just a shade. It's going to hit you as, wow, that's really darker, or that's really redder. And that's how you can tell the color of the nostrils if you got some sinusitis. You got allergies, they call them pale. They look paler than the cheek or the same color. Or some people call them blue and boggy, but I never see blue. You know, to me, that doesn't make any sense. When they could talk about the blue boggy allergy mucosa of the nose.
I've seen that, but it's kind of a blue tint. It's not really blue. It's just
Yeah.
a tint of blue.
But I see it paler, but,
It's
you know,
paler.
and it comes down to color, I guess. All right, wrong thing. I know. Yep. Okay, let me see. Okay. I want to do the pharynx. Okay, I keep saying I don't want to do this, but I do. Okay, there's a couple of the lips, and then the eyes, if we'll see what we can work out. But one of the big things that happens on the lips, is angular cellulitis. This is for somebody that has drooling. This is real common. Everybody's got an elderly aunt that has one. And your book talks about hairy tongue, and it has a black picture of hairy tongue. And this happens with antibiotic use on the tongue. And it tends to be on the back half of the tongue to the taste buds, which are your bumps along the side of the tongue. And a couple of years back, I had a young man come in and say, I've got these bumps on my tongue. And I said, they're your taste buds. But by the time he left, I'm sure he had the flu. It was the middle of the flu season. The man sat out there for 2 hours in the waiting room. So he came in with a hair, just regular taste buds, and probably left the flu. But hairy tongue, I've seen it in yellow. And you see it in books, and the first time I saw it in yellow, I thought, what have you been eating? But if you stop the antibiotic, it goes away in about 3 days. Sometimes it's 4, but it just gradually recedes. This below is just a varicose vein, sublingual. And, okay. In the back of the throat, if you look, here's the uvula, and look at the hard palate. And you've got the...
I'm sorry, I hate to interrupt. May I ask who is talking right now?
Amy Tim.
Amy Tim. What time does your class go off?
In 5 minutes.
In 5 minutes? In 5 minutes? Okay, because I had just turned it on for this class. It starts at 12, and the wrong thing came up on the screen, but you're fixing to leave?
Yes.
Yes. Okay, thank you.
Okay. All right. Torus plantinus is this right at the top, and it means Arab saddle, but it's a hard nodule at the back of the hard palate. This is a benign finding, but you'll see this in a lot of mouths. I want to tell you about the cobblestoning here. I'm going to get to tonsillitis, and I won't get to eyes. You want to notice that this pharyngeal arch is the same color all the way to the cheek. Can you see that? But in the back, you've got these white spots, and it's the light shining back at you, and they're a little bit elevated, and they have a sore throat. And this is what's called cobblestoning, and this is real common with allergies. Tonsils are graded. You've got this in your book. I talk about one thing about tonsils that you might see is a little pocket of something on the bottom of the tonsils, especially of large people, large tonsils rather. And so I said this on the tape, but what I meant to do here is, see this right back here at the bottom of the tonsil? If you will put a Q-tip, one of those long Texas Q-tips, you know, not the really big ones like you use in gin, but the skinny, long ones. And a lot of times if you see something at the bottom of the tonsil, just put that Q-tip and flake it up. And a lot of times it's a food particle, but it hurts because it's pulling on lymphoid tissue. A tonsil is your lymphoid tissue. So I want you to just know that sometimes you're going to see that, and people think they have tonsillitis time and time again. Now, what food does this the most? Crackers. And a little kid eating those little goldfish crackers. And so you'll see that. Okay, last 4 pictures here. Bottle teeth, you see that you're getting caries in the front of the teeth. You got a cleft palate. This happens at 12 weeks of gestation. Gingivitis here, see how red that is. And then you have hyperplasia. And you can get a fissured tongue in older adults. That's real common. Okay, cobblestone. When you see this on the computer, it'll look better. You've got some erythema in the pharyngeal arch, and this entire thing is red with some abscesses. All right, thank you.